Child sexual abuse and sexual violence against women and men is a public health issue. And we are very committed to having a conversation with you about what you can be doing as primary care practitioners and as often someone's first line of call, first contact, to be responding in a way that moves towards healing for children and for families and for adults who live with an experience of child sexual abuse or who've experienced sexual abuse as an adult.
A good GP highly values whole person care, and that involves caring for people from before they were born, right through until they die, and also caring about what goes on inside them, including illness, infections and diseases, but also the inner talking, where we talk to ourselves, the way we treat ourselves on the inside.
One of the things that we're learning, and we're particularly learning this from the stories that we hear and the wisdom of those with lived experience, is that telling your story about what's happened to you doesn't happen once. It's an unfolding story. It has chapters in it, and it has different impacts in different parts of someone's life. So just telling the story of something that's happened and having a mandatory response from a health practitioner or a primary care practitioner to ensure that someone is safe now and has the necessary supports from a legal perspective, actually that's not where it stops. We understand from the research that child sexual abuse and sexual violence against adults occurs across all demographics, across country and city, across cold communities, across different disability groups and within the queer community. So there's just a range of assumptions that we have to step away from and recognise that sexual violence is a problem across the board.
Primary health is really about the community. I come from a regional area, a remote, rural areas. It's so much harder out there than it is in a metro side of where you've got a greater choice. In the smaller towns, we don't have that choice. So we've got to have that better relationship with those people, and they then need to make sure that they understand what are the needs of the community out there.
So the people in our lives, the communities that we're in, the injustices and kind of oppressions we might have experienced, some of the practical things like housing and finances that can make people's lives difficult. So all of those things for me are important when you're being a good GP. Look, I think it's a real privilege to be there with people on the journey of their life. I see general practice, we're not necessarily going for cure, we're going for healing. There's been a number of R's that we talk about. The White Book has 8 of them, and the National Centre has 4 that they're focusing on, which are the core 4. Recognise, respond, refer, and reflect. 1 in 3 girls have experienced child sexual abuse, 1 in 5 boys. 40% of our community has had some exposure to domestic and family violence. And so in everyday consultation, these people are in our rooms, and being aware of how common it is should change our practice.
And the other thing we need to understand is that the long-term impacts of child sexual abuse and sexual violence are more and more understood now and are pointing to the need for us to be better in encouraging people to talk about it, recognising and believing what's happened to them, and supporting them to get some healing and treatment. We know that there is physical responses to trauma. We know that there can be physical impacts from the actual assaults, but also that there are internal wounds that take time to heal and related to somebody's trauma.
So I think for a GP to be able to say to someone, what happened to you is not okay, it really helps a survivor feel seen and believed and that we matter. And that's incredibly important. Shame can be crippling. And the shame that we feel as survivors, for many different reasons, can prevent us, or prevented me from wanting to speak out and admit it or voice it. You might feel uncomfortable listening to the stories, but sit with the discomfort. It's a lot harder for the person who's lived through it. So to be heard and seen, believed, supported is invaluable. It's priceless.
First of all, be really receptive, be aware of, that you are showing signs of active listening, and assure that child that they are going to be looked after and that you are there to make them feel better. Make sure that you're able to convey to that child that they can say anything to you, that there are no secrets when it comes to them feeling better.
We're bringing this awareness so that both the GP might bring it up, and also we might feel safer as survivors to voice that and to know that there's nothing shameful in what we've gone through. Not what's wrong with you, but what happened to you is such a powerful question. Don't be fooled by someone who says, I'm fine, there's nothing wrong with me. Particularly with adults, you could be more upfront and say, have you been inappropriately touched? Have you been abused or touched in a way that doesn't make you feel comfortable? With little kids, it has to be a little bit more gentle and age appropriate.
Listen to me. Listen to what I'm saying. Listen to what I'm not saying. In simplistic terms, look at me as a whole person, looking at all of the factors that are sitting behind what I've come to you for. Do what you say. So if you refer me, follow up with how that referral went.
We really aim for our patients to re-engage with their lives, no matter what has happened to them or what illness they still have. Rehabilitating the sense of self being our key goal of care. So I'm watching for them trying to stay safe in the consultation, and that can include them not telling me things or holding things back. And so we need to have that sensitivity to notice what's not being said as well as what's said. Reflection involves making sure we're still scientific in what we do. We can start to do unconscious things in our thinking, in our behaviour, in how we treat our patients. So I kind of weave them into my assessment and to make them normal, that it's normal for us to ask these things even if they're slightly uncomfortable and private. So each consultation needs to end with a sense that they felt safe during that time.
And that's why I'm glad that times are changing now, that we're bringing this awareness so that both the GP might bring it up, and also we might feel safer as survivors to voice that and to know that there's nothing shameful in what we've gone through.
Trauma-informed care is a kind of code for whole person care that GPs already value. And trauma-specific care is now, shown to be a beautiful range of care, including the expressive arts therapies that help us make sense through creating and through seeing patterns and colours and sounds and movement, through somatic sensory, so noticing our bodies. I guess there's a good thing about caring in this space is people can recover. You've got hope inside you that this person can go to a better place with the right care. And I guess the main thing is to not leave them alone with the story anymore. So for me, hope is a kind of lending hope to someone at the beginning of their journey, because we have seen so many go through the journey and come out the other end. Knowing that recovery is our goal, and recovery orientation is a kind of goal towards healing.
We just don't spend enough time understanding that. The GP to me is about healing. It's not about the medical side, the medicine side. It's about the healing side.
Commitment to people and community and helping people to heal is invaluable, and it's so appreciated. And survivors just want to be seen and heard and acknowledged. They want to feel safe. That's what we want, is to feel safe.